This conference will now be recorded.
Thank you, Christina. Thanks everybody for coming. My name is Greg Klingenstein. I'm a hip and knee surgeon at Reconstructive Orthopedics. So we're going to talk today about a topic that's near and dear to my heart, how to avoid hip surgery and what to do if you happen to get there. So here's a little outline of what we'll be talking about today. First, we'll be covering anatomy. So we're going to answer the question, where is my hip exactly? Then we'll look at sources of pain and try to figure out why is it that my hip hurts so much. After that, we'll have to look at the spectrum of disease, sort of a timeline of everything that can go wrong. Finally, how to avoid needing hip surgery in the first place. And lastly, we'll talk about how to prepare for hip surgery if you do get there. So where is the hip joint exactly? So the hip joint is a ball and socket joint right in the front of the hip. So it's not out on the side, it's not your butt, it's sort of deep within the groin. It's the type of thing you can't actually poke at, so you can't really feel it. So here's a diagram of the hip. This is the femoral head. It's about 2/3 of a sphere, and it's covered by articular cartilage, which is the gliding surface between the two bones. Then the socket side is called the acetabulum. So the hip is a ball and a socket right there. So then we got to ask ourselves, so what is it about the situation that actually hurts? Well, there's one structure called the labrum, which is a fibrocartilaginous ring that goes around the socket. The function is to deepen the socket, and it creates a suction seal and increases the stability of the hip. But it also has a lot of pain fibers. And so I believe this is sort of the check engine light of the hip. This is the thing that often hurts. So what are the major causes of hip pain? Well, we can divide it up into two categories. One would be intra-articular, which means inside the hip joint, and extra-articular, which would be outside the hip joint. So inside and outside the actual joint. So what are the things that can go wrong inside the hip socket? Those are the intra-articular disorders. One would be labral tears. That's that cartilage ring that goes around the socket. You can also have cartilage injuries, which would be the gliding surface between the bones. You can have fractures, you can have osteoarthritis. You can have inflammatory arthritis. That would be things like rheumatoid arthritis or lupus. We can see osteonecrosis, which means bone cells actually dying. We can see hip impingement. That goes by the name femoroacetabular impingement. We can have synovitis, which would be inflammation within the hip. There could be loose bodies, which would mean little chunks of bone floating around. And finally, tumors. Now let's look at extra-articular disorders, things that can go wrong outside the hip joint. We can have capsular problems. That would be like hip instability or adhesive capsulitis. Some people get a snapping hip. That can either be an internal snapping hip in the front or an external snapping hip out on the side. A lot of people get lateral hip pain. That means hip out on the side of the hip. That often comes from tendinitis or a tendon tear of your gluteus medius, and it usually results in trochanteric bursitis. You can get pubic pain, which is right in the front. That includes groin muscle tears and sports hernia. You might recognize that because that's the one that Donovan McNabb always used to get. Then you can have tendinitis about the hip, where some of the tendons will pull off a little chunk of bone in the front of the hip. We can also get nerve compression. And I put this last one in bold print because it's really important. Referred pain from the lumbar spine. I can't tell you how often people come into my office thinking they need a hip operation when they're actually having a back problem. All right, so now let's look at the 4 layers of the hip and supporting structure. So I like to think about this from the inside out. Layer 1 would be the bone and the cartilage. Layer 2 would be soft tissue. Layer 3 would be muscles, and layer 4 would be the nerve layer. All right, so let's start with layer 1. So we have the bone and cartilage layer. So what can go wrong with the bone? Well, we have hip impingement. That's a hip that doesn't move very well. Or we can have hip dysplasia. That would be a very shallow socket that actually moves too well. Then we have the cartilage that can undergo mild cartilage damage, and it can even turn into severe cartilage damage, which is really just another word for arthritis. And so here's a little example of a cam impingement, because this is important. I want to focus on here. Let's say we have a little bit of extra bone in the front of the hip, and every time you flex up, the bone is going to hit the labrum in the front of the hip. It's going to zoom in again so we can see it again. So watch as the hip flexes up, the extra bone deflects the labrum and shears off a little bit of cartilage over here. So this is hip impingement. All right, so let's look at layer 2 now, the soft tissue layer. So that incorporates the labrum and the capsule. Layer 3 is going to be our muscle layer. So here we've got our sports hernias, it's another word for athletic pubalgia, lateral hip muscle pain, that would be like a gluteus medius tear. You can have a proximal hamstring syndrome, hip flexor tendonitis, or even a back spasm. Now let's look at layer 4. That's going to be your nerve compression syndromes, pain syndrome, neuromuscular dysfunction, and spine referral patterns. So remember where we started from? People may come into the office and say, hey, I feel pain on the outside of my hip, and I have numbness and tingling going down my thigh. Well, we don't jump right to that nerve layer, layer 4. First, we start with layer 1, try to make the diagnosis, and work up from there. Because by the time you've gotten to a layer 4 nerve problem, you've probably been in pain quite a long time. And we need to pay attention to those underlying layers first. All right, so let's talk about the spectrum of hip disease. This is by far the most common thing that we're going to see. Let's start with labral tears. This is really just another word for early hip damage, where the ring around the socket becomes crushed. And this is a problem we normally see in young athletes, anyone from high school, 20s, 30s, once in a while in their 40s. And this can be caused by a hip impingement or dysplasia. Now, on the other end of the spectrum would be hip arthritis. This is late stage joint damage. This incorporates the entire hip socket. This we normally see in adults, ages 50s, 60s, 70s, and older. And this is treated with a hip replacement. So let's remember, labral tears over here for younger people is more of a sports injury that can be treated with a scope, a little camera. By the time the entire hip is worn out, like hip arthritis, then we're looking at a hip replacement. All right, so let's start with the young people first. How can we actually avoid labral tear surgery? I think the most important thing is to prevent overuse injury in children. Most hip problems can actually be detected early in adolescence, meaning that the hips are forming at the age of 7, 8, 9, 10. So those kids who are playing too many sports, playing the same sport again and again and again in elementary school, I believe are setting themselves up for problems. So we need to prevent overuse hip injuries in kids. The second thing to do is to learn proper body mechanics to avoid hip impingement. We saw on that slide before, the more a hip flexes up straight forwards, that can lead to injury. And there's really very few sports or activities that require such extreme hip flexion. Activity modification is going to be very important. I can't tell you how often a young athlete comes in and says, you know what, doc, it really hurts when I do one-legged squats. Well, you got to ask yourself, how important is a one-legged squat? Another important thing to keep in mind is the potential to change sports in young athletes. When we see a cross-country runner where it really hurts her to run more than 5 miles, maybe tennis is more appropriate, maybe swimming is more appropriate. Young athletes still do have the option to change sports. And finally, it's important to keep in mind that we can retrain athletes to avoid injury in their particular sport. So let's say a soccer player is hurting their hip with a big kick follow-through. Well, their trainer and the physical therapist needs to teach them to avoid impinging their hip, maybe kick a little lower. And there was a great article that came out this past year from a children's hospital in California, where they actually only had to operate at 18% of their young athletes that came in with labral tears, all by providing good physical therapy, retraining the body mechanics, and changing sports. So just because a young athlete has a labral tear does not mean they necessarily need emergency surgery. All right, now let's look at the other end of the spectrum, totally other end. Now for something completely different, and that's going to be osteoarthritis. So what is the definition of osteoarthritis? This is a degenerative joint disease in which the cartilage covering the ends of the bone deteriorates. This is the most common form of arthritis. It affects at least 27 million Americans each year. It's usually found in the knee, hands, or hips, and there's multiple contributing factors like advanced age, weight, lack of exercise, and previous injury. So we got to ask ourselves, what is it exactly that causes a hip to wear out? Now, just normal wear and tear, normal aging should not make a hip disintegrate on you. So normal joints should withstand the activities of daily life. When excess forces act on joints, injury and subsequent osteoarthritis may occur. Let me say that a different way. When the amount of force that your hip can withstand is too high, that's when the damage starts. And obesity plays a big role. So the prevalence of obesity has at least doubled in the last 25 years. And genetic factors are very important. So genetic factors play a role in more than 50% of hip arthritis. Then there's certain high demand occupations and high intensity athletics that can lead to a hip wearing out. So here's the etiology of hip arthritis according to Professor Ganz. This is one of the fathers of modern hip surgery from Switzerland. And he would say that hip arthritis isn't just bad luck. It's a structural problem that causes the hip to wear out. Some studies have shown that almost 80% of hip arthritis can be attributed to childhood hip disease. Meaning, if we had a good hip x-ray on every 18-year-old, we would probably be able to predict most hip arthritis. Another 10% have inflammatory arthritis, which is a medical autoimmune problem. And the converse is that populations with low rates of developmental abnormalities will have less arthritis. So here we go. How to avoid a hip replacement. Number one, have parents with super healthy joints. It's a little hard to go back in time on that one. Maintain a healthy body mass. Please stay active, but without overdoing the exercise. As a society, we need to do a better job of early detection of childhood hip disease. Here in America, every pediatrician moves a baby's hips back and forth listening for a click. While in England, every single newborn at least used to get an ultrasound looking for problems. Now, when it comes to avoiding a hip replacement, it's really important to have an open and honest conversation with your doctor to figure out, do you actually need hip surgery? Just because you have a radiology report that says hip arthritis does not mean that you need a hip replacement today. So I always ask my patients, what would you be doing differently if your hip felt better? If you're doing everything you want to do, you get your socks and shoes on, you're able to travel, spend time with your family, and your pain is controlled with over-the-counter pain medicines, you don't necessarily need a hip replacement. I would wait. And finally, a lot of people have been asking, can I just try stem cells instead? So let's spend a moment talking about stem cell therapy. So what is a stem cell exactly? It's a single baby cell that can replicate itself and differentiate into many different types of cells. So the best use for this, honestly, is childhood blood cancer, leukemia and lymphoma in children. When it comes to orthopedic surgery, some people have tried harvesting stem cells and just injecting it into an arthritic joint that is already worn out. And as of now, there is no conclusive evidence that injecting stem cells into an arthritic joint will regrow cartilage. In fact, according to the American Academy of Hip and Knee Surgeons, There are no proven uses of pain medications or any therapies that can actually delay or reverse the progressive joint destruction that occurs with osteoarthritis. Every medicine, every shot in the world are just temporary fixes. So let's look at it this way. When is the right time for a new hip? Do you actually change how you live your life based on your hip pain? Do you avoid traveling, seeing friends? Any trouble getting on socks and shoes? What would you be doing differently if your hip hurt? Now, hip replacements have been shown to reliably improve pain and function. However, a fake hip is still metal, plastic, and ceramic and will never function as well as your original hip. If a new hip replacement is not the hip you had when you were 25 years old. So let's talk a little bit more about total hip replacements. So the purpose is to relieve pain and restore mobility. They've actually been around since the 1960s. And currently there's about 400,000 hip replacements performed in the United States each year. So if you need a new hip, you're in good company. The hip replacement implants are designed to replicate your original anatomy, and the aging demographics are really driving up the number of surgeries done. So everybody is very interested nowadays with different surgical approaches in total hip replacements. Over here, we have a picture of the anterior approach with someone laying on their back. Here we have the posterior approach, which traditionally had a larger incision, but the most modern thing that we see most often now would be mini posterior approach. It's a significantly smaller incision, approximately a 4 to 5 inch incision. And finally, there's also a lateral approach also. So we're going to go through these right now. So the mini posterior approach, like everything else, has pros and cons. So the pros, good visibility and access to the hip. We avoid the abductor muscles, which like the gluteus medius, which is very important. And it can be used both for primary and complex hip replacements. The cons, the dislocation rate can be slightly higher than other approaches. And the typical posterolateral procedure will involve cutting into the iliotibial band and release of some or all of the short external rotators. Now let's look at the anterior approach. That's doing the operation from the front. So here we likely avoid the iliotibial band that's out on the side and the short external rotator damage. There's a reduced risk of hip dislocation, and sometimes there's no need for hip precautions afterwards. But this comes with a big risk. There is a higher risk of femur fractures. There's a much higher risk of injury to the lateral femoral cutaneous nerve, and that's the major nerve that supplies sensation to the thigh. Approximately 30% of people will have a large numb patch after an anterior hip. In this operation, the hip capsule in the front is actually removed. It's a little bit more technically challenging, and if there's any fractures, they are difficult to address from the front. Now, there are some very talented doctors in our area, particularly in our practice, that do a great job from an anterior approach. They can do revisions, they can fix fractures all from the front, so it is possible. The lateral approach is traditionally very popular in the Philadelphia area, is good visibility, makes the leg length easy, low dislocation risk. The cons, though, there's usually damage to the gluteus medius muscle, so a much greater risk of limping, and the incision is typically larger. So I'm going to spend a few minutes talking about one of my favorite approaches, and that's something called the SuperPath approach. It's similar to a mini posterior, but it's up a little bit higher. And this is a tissue-sparing approach where no muscles are cut. In the SuperPath approach, the hip is not dislocated, and the capsule is repaired anatomically. So the SuperPath muscle-sparing approach has actually been around for close to 17 years now. Back in 2003, someone came up with the idea of preparing the femur all through a small incision. And in 2004, someone came up with the idea of coming up with an extra portal in order to prepare the socket in a minimally invasive fashion. So the SuperPath is a hybrid approach. It's about a 4-inch incision, pretty small. The scar is a little bit higher up, and I do the operation mostly from the top down. I make an extra small 1/4 of an inch incision in order to insert a portal in order to prepare the socket. I cut the femoral neck without dislocating the hip. I'm able to preserve the ligaments around the hip because I'm not popping it out of place. And at the end of the operation, I'm able to repair the capsule side to side at the end. And the concept here is a faster return to full function. So preservation of key anatomical structures allows for early recovery, usually without postoperative restrictions. So the major structures we're talking about here is the hip capsule, the iliotibial band, the quadratus femoris, and the short external rotators. We're going to go over these right now. So why is the hip capsule important? This is a static stabilizer for the hip. It provides neurological feedback, and it contains the iliofemoral ligament, which is actually the strongest ligament in the human body. The SuperPath approach, I don't go into the iliotibial band. This is the largest piece of fascia. It provides attachments for the gluteus maximus and the tensor fasciae lata. Some people refer to it as the deltoid of the hip as a pelvic stabilizer. And if you do need to cut into it, it can be a source of pain and compromised gait, even if you do repair it. So the short external rotators and the quadratus. The short external rotators function to externally rotate the hip, and they do provide some stability. Most importantly here is the quadratus. That is this muscle down over here, and this has a major blood vessel in it. So when you hear stories about people needing transfusions after a hip replacement, it's usually because the surgeon is cutting into this muscle. So if we can leave the muscle alone, less bleeding, we will rarely need a blood transfusion. One of the reasons I really like the SuperPath approach is fewer complications. So the portal-assisted acetabular preparation allows for placement of the cup with really seeing what I'm doing. In addition, I always like to use computer navigation as a second check to make sure I'm putting in the implants correctly. Again, we're going to preserve the quadratus femoris to reduce the risk of postoperative bleeding and transfusion. In order to get my leg lengths, I reference off the greater trochanter, and there's a reduced risk of fracture. By preparing the femur first and not tearing the hip out of the socket, we can reduce the risk of postoperative dislocation. And if anything were to go wrong, I just extend the incision a little bit, and it becomes a standard posterior approach. So from a patient's perspective, what's the advantage? Reduced hospital length of stay. I have good data to show that, at least in our hospital, my SuperPath hips do go home faster. Almost everybody gets discharged directly home, no need for a rehab center. I do these operations now at our outpatient surgical center where you walk out the door just 2 to 3 hours after surgery. So let me summarize the surgical approaches. So your surgeon will choose the approach that they feel meets your needs. Now, the dirty little secret is that the most recent studies show no significant difference between the anterior, lateral, and mini posterior approaches. So again, we just spent all this time talking about different surgical approaches. At the end of the day, as long as you rehab correctly, you're a good candidate for surgery, and the doctor puts the pieces in right, you're probably going to do just fine, no matter where your scar is. So overall, hip replacement surgery is typically very successful in relieving pain and restoring function to arthritic hips. Now let's talk about choosing a surgeon. So we just said most recent literature shows equivalent outcomes between surgical approaches. So I'm going to say the most important thing to finding a surgeon is to find somebody you trust and feel comfortable with. I highly recommend going with a high volume specialist as opposed to the occasional hip replacement surgeon. You want to look for somebody who has specific fellowship training in joint replacements. A great place to start would be the AAHKS website. That's the American Academy of Hip and Knee Surgeons. So all AAHKS members are board certified orthopedic surgeons that perform more than 50 joint replacements each year. So that's a good jumping off place to find a doctor. All right, and finally, how do we actually get ready for surgery? What are the things we need to do when that day finally comes? Firstly, maintain a healthy body mass index. Your recovery is going to be faster, your surgery will be faster, and you will do better if you can maintain a healthy body mass. For very, very heavy people, the surgery may actually be contraindicated because the rate of infection can be unacceptably high. Getting ready for surgery, it's important to have a well-balanced diet, high in protein. You're going to need that protein for healing. Keep your body as strong as possible, and this can be very hard. When you have an arthritic hip, you just don't want to move. Your hip's in the center of your body and everything you do hurts. But it's going to be important to get on an exercise bike, lift some light weights, try to keep your body as strong as possible. It's going to be very important to quit smoking and avoid any nicotine products prior to the operation. Again, your risk of complications goes up dramatically if you're using nicotine products. Next, let's look at diabetes. You need to make sure that your blood sugar is as well controlled as possible. Next, let's talk about pain medication. It's very dangerous to take opioid pain medication like Percocet or Vicodin or Dilaudid or fentanyl prior to your operation. There's a much higher chance of pain, infection, failure, and the need for chronic opioids if you're taking opioids before the operation. So for people on pain management, we highly recommend that they get off the medications prior to surgery. Next, it's going to be very important to manage your anxiety and depression as much as possible. For people that do have underlying anxiety and depression, something that may be a mild pain will manifest itself as a more severe pain after surgery. So it's going to be very important to talk to your family doctor, or maybe if you find a behavioral health professional prior to the operation, so you can be as good as you can get prior to the operation. And finally, it's important to find a joint replacement coach to help you through your recovery. This could be a friend, a sibling, a spouse. You really need somebody that you can trust, somebody that's going to go with you to your preoperative class, somebody who's going to check in with you after the operation, somebody you trust who's going to be with you each step of the way. Okay. Now it's time for questions.
Thank you, Dr. Klingenstein, for such an informative presentation. Like Dr. Klingenstein said, we'd like to open this up for questions. So please feel free to either type them in the chat box, or you can go ahead and unmute yourself. As long as we don't have it, as long as we're not having more than one person speak at the same time.
All right, Dr. Klingenstein, can you hear me?
That must be Joan.
Yes, how did you know that? Okay.
We've known each other a long time now.
What?
We've known each other for quite a few years now.
Yes, we have. We're very frequent flyers with you, aren't we? My mother broke both of her hips, and my DEXA scan is showing osteoporosis already in my right hip. My primary care doctor, Bross, would like me to go on Prolia. I had taken Fosamax orally some years ago, and it just tore my stomach up one side and down the other, and I couldn't take it. What are the side effects with the Prolia?
All right, this is a whole talk within itself. We should do another time. So in a nutshell, the older osteoporosis medicines were really only approved to be used for 3 to 5 years at a time, kind of like Fosamax. And they did have side effects in the long run. And one of them was something called the bisphosphonate fracture. So once in a while, we meet somebody who was on Fosamax, unfortunately, for 8 years, 10 years, 12 years, way more than the recommended 5 years. And for those guys, bones can actually break. Now, the newer medications like Prolia tend to be a lot safer. And those really should be monitored by rheumatologists as opposed to orthopedic surgeons. So I hear people ask that all the time. You know, they say, I'm afraid of a osteoporosis medicine. What about the side effects? I flip it around and look at the other way. If somebody really has severe osteoporosis, their chance of breaking a rib, a pelvis, a wrist, or a hip could be as high as 20 to 30%. So on one hand, you're talking about a rare complication. On the other hand, you're talking about a 20% chance of major life-changing fractures.
Yeah, I broke my wrist a couple months ago.
So I think we really need to weigh the risks and benefits. Now, Joan, you're young, so it's not that big a deal, but for an older person breaking their hip, that can be deadly. In some ways,
I'm 68. I'll be 69 in September.
So young. So it can be deadly. So I think in some ways those osteoporosis medicines are very important.
Okay, I guess I'm calling a rheumatologist then, huh?
I think it would be a good idea.
Okay. Okay. All righty. Thank you, Dr. Klingenstein. I appreciate your input.
You're very welcome.
Dr. Klingenstein, this is Pat.
Hi, Pat.
One question. Will I be able to ride my horse after surgery if I have to have a replacement?
You should be able to ride a horse. I've had a bunch of patients, especially in the southern New Jersey area, that own horses, and just about everybody's gotten back to riding horses after surgery.
Okay, good. That's my biggest question. Thank you.
I'll tell you though, the biggest predictor of what you can do is what you're doing before the operation. So, you know, if you ever meet somebody who wants to get back to an activity and they haven't done it in 20 years, that might be hard. But if you're riding horses right up until the time of your hip replacement, that should be fine.
Great. That's what I wanted to hear.
Thank you for the questions. Did anybody else have a question this evening?
Yeah, this is Elizabeth. I was just wondering what other exercises might be good to strengthen hip areas. I do have osteoporosis and I do experience some pain in my hips. I'm trying to do walking. Haven't gotten the bike out yet, but when I get the air in the tires, we'll start riding a bike again. What other types of things would be helpful?
Well, it really depends on what kind of condition your hips are in. So for someone with very severe arthritis, it's going to be very hard to ride a bike and do a whole lot. But for people who don't have severe arthritis, I'd really focus on abdominal exercises, core exercises, low back, and then we're talking about your quads and hamstrings, and also your gluteus medius. That would be the abductors out on the side.
Okay. All right, thank you.
All right, Dr. Klingenstein, it's Joan Beach again. I have one more question. I've been having pain down my right side on the outside of my hip. It's been for quite a while. I mean, I can't even lay on that side, sleep on that side. I have to sleep on my left. Will the Prolia help that? Is that something that I should see you about?
So that is something we should talk about. So Prolia as an osteoporosis medicine does not relieve pain. So for the most part, you can't feel your osteoporosis unless there's a small fracture.
Okay.
For people that have pain out on the side of the hip, that's usually coming from one of three sources. One would be a pinched nerve in your back. One would be a tendinitis out on the side of the hip, which then causes bursitis and the whole side of your hip hurts. And lastly, if you have hip arthritis, it can actually make the side of your hip hurt also. So it's usually one of those three things.
Okay. So what do I do about that?
I'll have to see you back in the office and examine you and figure out what the next step is.
Make an appointment with you. All right.
Yes, please.
Okay. Thank you, Dr. Klingenstein.
Thank you for the great questions. Was there anybody else who had a question this evening?
This is Elizabeth again. I do have a question about something that the other woman just made me think about. I do sometimes get the pain going down. I don't know if that's, there's some name for it, I guess, where it goes down your leg. But on two occasions, and one of them was recently, I would get out of the bed in the morning and my leg just gave out. I didn't fall all the way, but it just like buckled. And I don't know whether that is indicative of a problem with the hip or the knee or strength or what.
You know, it's hard. If the entire leg gives out on you, it could be your lower back, your hip, your knee, your ankle, or anything in between. So, you know, it's up to the doctor to really pay close attention to the whole kinetic chain to figure out what's going on.
I do have existing lower back issues and have had them for it's chronic, but I don't know what it was. Okay, well, again, back to a less strengthening. Maybe that'll help. Thank you.
You're welcome.
Are there any other questions this evening? All right, well, if there's no more questions, Dr. Klingstein, I'd like to thank you again for your time this evening and like to thank everybody for joining us. And I'd like to say have a good night.
Thank you very much for having me, and thanks everybody for coming.
Have a good night, everybody. Thank you.
Thank
Thank
you.
you.